Good morning. I'd like to thank the moderators for the opportunity to give this presentation. Today I'll be discussing baseline psychiatric diagnoses lead to increased hospital length of stay and early readmissions after bariatric surgery. Psychiatric illnesses are highly prevalent in obese patients. In fact, studies that have looked at this have found that almost 40% of bariatric candidates meet criteria for at least one psychiatric illness at the time of preoperative evaluation. As such, the goal of preoperative psychiatric screening is to identify patients who have psychosocial risk factors that may impede their success after bariatric surgery. Patients who are found to have uncontrolled psychiatric diagnoses are considered inappropriate candidates and are screened out from the process. Interestingly, patients with a psychiatric history who make it through screening have been found to have comparable weight loss outcomes after bariatric surgery. Although in our own quality review meetings, we have found that many patients with early and frequent readmissions had significant psychiatric histories in their intake psychiatric screening evaluations, including depression, anxiety, and bipolar disorders, or DAB. And so what we wanted to understand is what the impact of well-controlled or historical diagnoses of depression, anxiety, and/or bipolar had on early postoperative outcomes after bariatric surgery. We hypothesized that patients with a baseline or history of DAB would be at a greater risk for increased hospital length of stay and early readmissions after surgery, but that these patients would have comparable weight loss outcomes postoperatively. We conducted a retrospective review of all patients who underwent primary bariatric surgery from 2014 to 2016 at our institution. We collected demographic data as well as data regarding baseline or historical diagnoses of depression, anxiety, and bipolar disorders. And the postoperative outcomes we looked at were percent excess body weight loss at 2, 6, and 12 months, 30-day readmission rates, and hospital length of stay. Overall, we had 354 patients who met our inclusion criteria during the study period. The mean preoperative BMI was 49, most underwent a sleeve gastrectomy, and the majority were female and Caucasian. We had 54% or 191 patients who either had a baseline or history of depression, anxiety, and/or bipolar disorder, with the most common being major depressive disorder followed by anxiety disorder, and 13% actually had both depression and anxiety disorders. When comparing our control to our DAB group, there was no difference in mean preoperative BMI, insurance status, and surgery type. However, there were significantly more female and Caucasian patients in our DAB group compared to our control group. When evaluating 30-day readmission rates, overall, there was a significantly higher 30-day readmission rate compared to our control group for the DAB patients, 10.5 to 3.7%. When stratifying by surgery type, although these did not reach statistical significance, you can see a similar trend, 11% to 3.2%, and again for our sleeve patients, a more than doubling of 30-day readmission rates in our DAB patients. We wanted to break this down further by psychiatric diagnosis, and as you can see here, each cohort of psychiatric diagnosis does have an elevated 30-day readmission rate compared to the control group, although for patients with depression and those with depression and anxiety, this only trended towards significance. For those with anxiety or bipolar disorder, these were highly statistically significant. Next, we looked at hospital length of stay. Overall, the mean hospital length of stay between these two groups was not statistically different. When we stratified by Roux-en-Y gastric bypass, again, this was not different. And then for sleeve patients, although the mean was slightly higher for depression, anxiety, and bipolar, it was not statistically significant. We wanted to look more closely at hospital length of stay, and one metric we had found in our own institutional data was that length of stay greater than or equal to 4 days was independently correlated to readmission rates. So we looked at this metric, and as you can see, the incidence for long length of stay is higher in our depression, anxiety, and bipolar patients, although this is not statistically significant. Again, with Roux, there's no difference. And then with sleeves, although this only trends towards significance, you can see a more than doubling of the incidence of long length of stay for our DAB patients compared to our control group. As we had done with our readmission data, we looked at this by psychiatric cohort, and as you can see, all the cohorts have an elevation in the incidence of long length of stay compared to the control group. This was only statistically significant when comparing patients with both depression and anxiety compared to our control group, although this did trend to significance for bipolar patients, where even in a small cohort of 11 patients, you're seeing almost a doubling of that incidence. When looking at weight loss outcomes, there was no difference for 2-month percent excess body weight loss between our control and our DAB group. At 6 months, there was a significant drop in excess body weight loss for our DAB patients, 41% to 46%. but at 1 year, the weight loss outcomes were comparable between both groups. And these results held true even when adjusting for surgery type. In summary, major mood and anxiety disorders are highly prevalent in this cohort. Patients with depression, anxiety, and/or bipolar disorder did have a significantly higher early readmission rate compared to our control group. And those patients that had both depression and anxiety were significantly more associated with a hospital length of stay of greater than or equal to 4 days. Although patients in the DAB group did have lower 6-month % excess body weight loss, their weight loss outcomes were comparable 1 year after surgery. Obviously, this is limited by its retrospective nature, and as well as the fact that there are small cohorts within each specific psychiatric diagnosis, most specifically our bipolar disorder group. And although we categorized psychiatric diagnoses both well-controlled versus historical together, we do realize that these probably represent two distinct populations, and future studies will look at delineating the risks of these two categories. In conclusion, however, we believe our data shows that patients with a history of or well-managed DAB are at a higher risk of early readmissions after bariatric surgery, and that patients with multiple psychiatric diagnoses are more associated with a hospital length of stay greater than 4 days. So future studies will have to focus on determining what exactly the impact of these diagnoses have on these metrics in order to figure out a targeted intervention for more appropriate perioperative support. Thank you.